This video is an introduction to diagnostic knee arthroscopy, loose body removal, and partial menisectomy. These are my disclosures. And I'd like to give a big thank you to both Rob Pedowitz and Mark Hutchinson for their outstanding mentorship of me over the years and for allowing me to borrow some of their slides, which have been used many times at the Orthopedic Learning Center for various resident courses. Before we get into diagnostic arthroscopy, I think we need to focus a little bit on positioning. In general, there's several different types of leg positioners that people use. They use well leg holders or posts most commonly. When positioning, it's extremely important to make sure, especially when the patient is supine, that their kneecap is either pointing superior or is slightly externally rotated. I often see a position with the kneecap slightly internally rotated, and this will make it much more difficult to achieve the appropriate amount of varus or valgus stress on the knee to be able to visualize optimally. Surgeons typically use several different portal techniques. So there's a two-portal technique where there's a working portal and a viewing portal, and your inflow and outflow is run off of the arthroscope. And then there's the three-portal technique, which uses the same working portal and viewing portal, but runs the inflow or outflow separately, either through a superior medial or superior lateral portal. In general, this is surgeon preference in terms of which of these techniques you would choose. Portals can also be made horizontally or vertically, and there's pluses and minuses to both. So the horizontal portals generally are in Langer's lines. They're more cosmetic. They can be extended medially and laterally. And vertical portals are able to be extended superiorly and inferiorly. In my practice, I typically will use vertical portals if I have obese patients and I'm not able to really be confident in my anatomy for portal placement, because it's a bigger error to have a portal too high or too low, and I like to have the ability to extend in these patients if necessary. If I'm very confident in my palpation of the patient's anatomy and understanding of where the portals should go, then I generally make horizontal portals. The key point is that you just want to do whatever technique you can to make sure you get them in the correct position to allow you to accomplish what you've set out to perform surgically. There's lots of portals to choose from. You can see them identified here. So most surgeons will definitely use the anterior lateral and anterior medial portals. Those are the workhorse portals for both visualization and working. And some surgeons will also use a superior medial or superior lateral portal as their inflow or outflow. There are several different accessory portals which are identified in these images, which can be used for different techniques. So accessory portals are often used for loose body removal or for ACL reconstruction to get optimal positioning of tunnel placement. The central portal can be used to visualize into the posterior knee. The key is getting them in a good position. And so these next two videos are going to show how to establish the anterior medial and anterior lateral portal. We generally start with the anterior lateral portal, and the way that I identify this best is by using my thumb to palpate the superior edge of the tibial plateau, and then I mark the portal just above that thumb. In some instances, often if a patient is obese or has had the portals injected, you can't really get a good feel of that superior lateral tibial plateau. And if that's the case, it's helpful to have some other tricks in your bag. So one of those is using the goalpost technique. You can palpate the inferior pole of the patella and draw a horizontal line, and then mark out the medial and lateral borders of the patella and draw vertical lines. In general, your lateral portal usually ends up where those two lines intersect. Another method you can see being demonstrated here is the bubble test. So pushing on the patella tendon causes this outpouching or pooching of fluid in this space, and you can see that that portal usually lines up kind of right in the middle of that egg-shaped circle. So when you're first starting, if all three of those things line up, you can be pretty confident that you're putting your anterior lateral portal in a good and safe place. Finally, if you have patients that are extremely difficult with odd anatomy or obesity, you may use an 18-gauge spinal needle to try to localize to the notch just to make sure that you can get it in there without bumping or running into any other structures. Also to note, the type of the operation sometimes dictates a slight deviation from a standard portal site. So for me, if I'm doing an ACL and I know I'm going to be predominantly working in the notch, I generally will move my portal closer to the patella tendon to facilitate that process. The anterior medial portal is created under direct visualization. We generally use a spinal needle to optimize the position of the portal. You start by looking at the capsule and then orient back over to the posterior horn of the medial meniscus to ensure that you can get that spinal needle to your target tissue. So here you're trying to do a partial menisectomy. You want to make sure you can get there with that portal. Once that's verified, you then will insert a knife blade along the same trajectory, and again, looking at the capsule so that you're doing this under direct visualization and ensuring that you're not causing any iatrogenic damage to either the meniscus or to the cartilage. It's important when you're doing this that you give yourself a really wide field of view. So I often see residents kind of telescoped way in on the condyle, and then they can't see either the knife or the spinal needle coming into view, or they angle their spinal needle more towards the notch. If you look at the knee for a second, when you have the arthroscope positioned in the medial compartment, you'll actually see kind of a bright red light where the skin is, or on the skin where the light is, and you'll notice that that's almost straight back from where you're having your starting position. So when you're triangulating, you're usually inserting that spinal needle straight back and slightly down, as opposed to across the knee, which is where the tendency is for beginners. So it's helpful to take your eyes off of the screen when you're doing this and to look down at the knee to make sure you're kind of triangulating until that becomes second nature for you. In general, again, you want to give yourself as big a field of view as possible. So when you're starting, it's usually easiest to work if you have a wide field of vision. You can't scope if you can't see. So really just telescope back until you're almost all the way out of the joint, and you get to that point where you're about to fall out, just stop. And then don't forget to take advantage of that 30-degree angle on the end of your light source by periscoping. So you want to kind of look where you're going, or look at that tissue that you're trying to target. I'd encourage you to optimally position your arthroscope and visualize before you start moving your instruments, especially when you're beginning. And then you want to make sure that you develop your own standard order of procedure. It doesn't really matter which order you do your diagnostic arthroscopy in, as long as you're visualizing all aspects of the knee. The order of steps that I use is listed over here on to the right. So I generally will start in the suprapatellar pouch. I'll look at the medial shelf plica and the portal plica. Often there's loose bodies in this area. I'll then go over to the lateral gutter, which one of my mentors used to call the wastebasket of the knee. This is a common spot for loose bodies and other debris, and it's very important to check this area. You also visualize the popliteal tendon here. Then I'll come back up over into the suprapatellar pouch and then down the medial gutter, looking at the deep fibers of the medial collateral ligament and the capsular attachments of the meniscus. We then will enter the medial compartment and look at the meniscus, femoral, and tibial condyles. We'll move over to the notch and look at the ACL, the PCL, and the ligamentum, and then go into the lateral compartment, again evaluating meniscus, femoral, and tibial condyles in that compartment. And finally, we'll back out and head over to the patellofemoral compartment, first looking at the distal femur in its entirety, and then extending to the patellofemoral joint and specifically evaluating tracking, and then looking at the lateral patellar facet, the medial patellar facet, and the apical ridge to see whether there's any chondral damage. It's also very important that you know and understand how to look into posterior medial and the posterior lateral compartments of the knee. These are common areas for loose bodies and sometimes are required for certain surgical procedures like PCL reconstruction or meniscal repair. And especially if you're practicing with cadavers or other opportunities, it's really helpful to make sure that you know and understand how to get back into those compartments. So this is an example of just looking in the suprapatellar pouch. You want to make sure that you do this in full extension. You should never put the scope up into the patellofemoral joint in any level of flexion. This narrows the space and obviously increases the risk for iatrogenic cartilage damage. So you want to stay fully extended when you're up here. And generally, I just visualize this area by moving the light source and periscoping from 9 o'clock to 3 o'clock so we see the entirety of the suprapatellar pouch. I'm looking for loose bodies, inflamed synovium. I want to identify the portal plica and the medial plica. We'll look at the undersurface of the quadriceps tendon. If you're using a 3-portal technique and you have an outflow cannula here, sometimes when you initially stick that in, it'll get clogged with debris. You want to make sure that that's not clogged so that you actually get good outflow. Then we'll move from the suprapatellar pouch into the lateral gutter. It's key to remember you want to look where you're going and then go there. So as you're moving left across the suprapatellar pouch, you're going to be looking more towards 3 or 9 o'clock. And then when you start going down the gutter, you're going to aim at 6 o'clock to look down and then go down. The other key thing to note, and I see residents get hung up on this all the time, is that there's this synovial fold right here. And if you're telescoped in too far, you're just going to ride and jam on that synovial fold. So if you feel yourself doing that, remember to back up. Once you see the fold, then you can raise your hand and get over there easily. If you want to visualize the popliteal tendon, sometimes you need to slightly flex and then orient more along the horizon. Milk the joint to look for loose bodies posteriorly, and you want to examine the lateral meniscus margin, and then head back up into the suprapatellar pouch again, go over the top and into the medial gutter. This is all done again with the knee fully extended so that you're not risking any cartilage damage in the suprapatellar pouch or the patellofemoral joint. In the medial gutter, you want to evaluate the deep fibers, the MCL and the synovium, and the capsular attachments to the medial meniscus. Once you've completed that, then we want to establish and optimize visualization in the medial compartment. So this is generally done by placing the knee in slight flexion. So a common resident error I see is that residents put the foot right up on the hip and the knee is positioned lower than their body, and this forces the knee into full extension. It's very difficult to open space and get into the posterior compartments or the posterior horn of the medial meniscus and actually see that in this position. So remember to flex to about 15 to 30 degrees. Try putting the leg on your thigh and make sure that you can see that bend in the knee when you're physically looking at it. The other thing to note is that in general, the best visualization is achieved with your arthroscope oriented along the horizon. So you basically, once you get in and you're going to start working with your probe, orient the hash on the scope. So you want to periscope over to the position of the posterior horn of the medial meniscus. So we know the posterior horn of the medial meniscus is here. We want that little hash mark right there. That sets us up for optimal visualization in the medial compartment, and you're going to really use the same position for the notch and the lateral compartment and the patellofemoral joint. So that's how you can set it. You want to make sure that you're probing the meniscus thoroughly. So you can see in this video that there was this little retained fragment flipped down underneath the medial tibial plateau, and we then flip it into the joint and then it shows itself. It's important to recognize those because that's a common source of continued pain, obviously, if it's not excised during the procedure. Also, you don't want to forget to probe the articular surface and make sure you're flexing and extending the knee so that you see the entirety of the posterior condyle of the femur and identify whether there's any articular cartilage defects. Once you're done with the medial compartment, you'll move over to the notch and visualize the ACL and PCL. In the notch, there's the ligamentum and the fat pad. And so the fat pad is the young trainee's kind of worst enemy. In order to get up over that, you'll want to see the femoral condyle and track yourself right up on top of that so you can get over the top of this ligamentum and then see down into the area of the ACL. If you just sweep from left to right, you're going to catch that ligamentum and it's going to pull the fat pad into your picture and obscure your view. And so in some cases, that ligamentum and fat pad just obscure too much, and you may want to excise it. If you're going to do that, you don't want to just start shaving the fat pad. You want to just detach the fat pad at its attachment so the fat pad is tethered by that ligamentum at the superior part of the notch. And if you just remove that part, the fat pad will fall out of your way. So you're not debriding this highly vascular fat pad, and you actually have a better field of view now that the fat pad just kind of fell out of the way and we can really see our ACL and our PCL. Once that's concluded, to ready yourself to go into the lateral compartment, you can park your probe in the spot just adjacent to the anterior cruciate ligament and the lateral femoral condyle. Right there. And now we're ready to get into the lateral compartment. This is generally done in the figure of 4 position. And so before you get into the figure of 4 position, it's easiest if you park that probe and then you look to see the L shape that's made between the anterior cruciate ligament and the anterior horn of the lateral meniscus. If you can't see that and it's obscured by fat, then you're going to need to do a little bit of debridement by the fat, or you're going to need to release that ligamentum so that it pulls out of the way so that you can easily get in that compartment and visualize. Once you're able to see that anterior horn of the lateral meniscus, then you want to just maintain your view directly on that as you extend the leg and you push yourself into the figure of 4 position. If you do that, you'll fall into the compartment nicely. Once you've accomplished that and gotten into the figure of 4 position, you can now probe your lateral meniscus. You can probe the superior and inferior surfaces and then probe to look at the popliteal tendon and the popliteal hiatus. It's important to note that that light source initially was oriented along the horizon, and now I've kind of moved it towards the 6 o'clock position to be able to take advantage of that periscoping to see the anterior horn of the lateral meniscus. And then I'll often orient it back up towards the 2 o'clock position to look at the undersurface of the femoral condyle and to flex and extend the knee, again, to ensure that there's no cartilage defects on the distal surface of the femur. You want to come towards full extension so you can really see that weight-bearing surface, as you'll often see that that's areas where there are some chondral defects. Once that's completed, we'll go into the patellofemoral compartment. You'll start in flexion and evaluate the entirety of the distal femoral condyle. And once you feel that you've really seen all that cartilage in the distal femoral condyle, then you'll come up and look directly at the patellofemoral joint and evaluate patellofemoral tracking by slightly flexing and extending the knee. Again, notice the arthroscope orientation still back towards that, 3 o'clock position here, which was the posterior horn of the medial meniscus initially. After we've completed a look at the patellofemoral tracking, we'll want to look at the medial patellar facet, the lateral patellar facet, and the apical ridge of the patella to ascertain whether or not there's any chondral damage. Once that is complete, that completes our diagnostic knee arthroscopy. In some cases, you're going to want to go and evaluate the posterior compartments of the knee. And the best way I find to do this is to use the contralateral portal to insert the arthroscope behind the PCL tendon and look into the posterior medial compartment, and then basically the same thing to go underneath the ACL to look into the lateral compartment. In general, this is done with the knee in flexion, and if you can't easily get in there by just moving and maneuvering the arthroscope in there, consider putting the arthroscope into the position where it's lined up in that spot just under the PCL, and then removing the arthroscope and inserting a blunt trocar to easily push it in there so that you're not causing any iatrogenic cartilage damage. Once you're visualizing in the posterior compartment, if you find you need to do work there, you need to know how to establish safe posterior portals. And I'd encourage you anytime, if you're using a cadaver or some other method to practice, that you really take advantage of that opportunity to get very comfortable at doing this. So there is a little bit of danger creating posterior portals. On the lateral side, you have your peroneal nerve, so it's important to remember that that lies below the biceps femoris. So you'll feel and palpate the fibular head, you can feel and palpate the biceps, and as long as you stay superior to that, you should be safe. And then on the medial side of the knee, there's the saphenous nerve and the sartorius and pes anserine tendons. And so you want to feel that superior border of the sartorius and make your portal above that. Another very helpful thing is when your arthroscope is shining into that posterior medial, posterior lateral compartment, you'll see a red ball of light on the side of the knee. And in general, your starting point is going to be at the posterior superior-most aspect of that circle. So I find that that's a good starting point as long as you're above either the biceps femoris or the sartorius. This is a little video example of doing a diagnostic arthroscopy and getting into the posterior compartment so you can see where we're going in. I'm using the light source, kind of moving it left and right to decrease the level of friction as we pop into the posterior compartment. You can see the posterior femoral condyle, and then we're going to look up at the superior capsular reflection. And then as we start to back out, we can kind of look down and visualize the posterior horn of the medial meniscus. And as we look over to the right, we'll see the posterior cruciate ligament and the septum between the posterior compartments of the knee. When you're working in the medial compartment, again, portal position is very key. If you were too high or too low, you're going to be either levering off the femoral condyle or levering off the tibia and not able to actually get to that posterior portion of the meniscus. The other is the positioning of the knee when you first set the patient up. If they were in a lot of internal rotation to begin with, it's going to be very hard to get the appropriate amount of valgus to really get safely to that posterior horn. Triangulation from the FAST program that you just completed is important to remember. Again, you're operating more straight back into the medial compartment as your visualization is kind of coming across. So it's important to remember those concepts as you triangulate to your target tissue. You want to remember that that compartment should be in slight flexion, again, to optimize visualization, and pull back to improve your field of view. In the lateral compartment, we generally do this in the figure of 4 position. You can see that here. Often you'll use an assistant to help hold the ankle on top of the patient's contralateral leg, and you may need an assistant to push on the knee to apply additional varus stress to open up that compartment in some patients. So the goal of this presentation is hopefully to get you to avoid some of the common rookie errors that we see. The biggest one is that residents tend to push their arthroscope way up close to the tissue that they want to be looking at, so much so that it's unrecognizable. So this is like an ACL, and when I'm looking at it, I'm not sure. It just looks like a big blob of soft tissue. If you ask the resident to get perspective or pull back, then all of a sudden you can see the whole picture. You can see that whole ACL, PCL, and notch. It makes it a lot easier for them to do their work. When you're working, you want to work from known to unknown. You want to make sure that you maintain that horizon. If you do that, then generally things that are up, and things that are down, things that are left, and things that are right. It just makes your brain work easier, especially as you're starting out. Remember to take advantage of the 30-degree angle on the tip of the arthroscope to get that best field of view. So periscope to the degree that you need. I can't tell you how many times I've actually seen people trying to look at the ACL and PCL, but they have the arthroscope looking towards the front of the knee. You want to be looking directly at that tissue. Try to keep your camera stable and work your instrument into view. Early on when you're training, it's best, again, to have that wide field of view and be working in that wide field of view as opposed to trying to move things both at the same time. That'll come as you develop that kind of eye-hand coordination and bimanual dexterity. And as you get better at that, that'll become easier. For loose body removal, there's a few pearls. So first, you want to make sure you do a thorough diagnostic exam. You look behind those plicas, you look in all aspects of the knee to find the loose bodies. Often they're floating around and they may not be in a good position or somewhere easy for you to access. So you can use the tip of your arthroscope to move them into an easier place of the joint to get a better grab, or you can use your probe to do that. The other thing that's important to remember is that your arthroscope usually has inflow coming off of it, and if you're blowing a bunch of water, you may constantly be blowing the loose body away from you. So one strategy there is just to turn off your inflow for a brief second while you then go in and grasp the loose body to remove it. It's very important that your portals are big enough and that you have a really good grab on the loose body so that you don't accidentally leave the tissue or leave the loose body in soft tissue as you're trying to extract it. And when you're approaching the loose body, open your grasper so that you avoid nudging it posteriorly. I can't tell you how much of a mood breaker it is when you're in the lateral compartment and you see the loose body right there, and then somebody goes in and they nudge it into the posterior lateral compartment, and then it doesn't come out, and then you find yourself having to make a posterior lateral portal and doing a lot more work and causing another incision for the patient for something that you possibly could have grabbed without needing to do that. In general, loose bodies tend to live in the lateral gutter, again, the wastebasket of the knee. They can be up in the suprapatellar pouch. I've found them sitting behind the portal plica, so if you don't get back up there and look in there, you might miss one. Posterior, medial, and lateral compartments are favorite spots for loose bodies to live, so again, it's very important to make sure that you're looking in these areas. The intracondylar notch is another area that often will see loose bodies. For partial menisectomy, our goal is to remove the least amount of tissue as possible. The more tissue you remove, the more joint reaction forces increase, and the more the likelihood of arthritis developing in the future increases. And so you want to come up with a plan beforehand to remove as little of that meniscal tissue as possible, but obviously you want to prevent a recurrence. In order to prevent a recurrence, you want a balanced, stable rim when you're done. You want to avoid iatrogenesis imperfecta, which is basically cartilage damage from putting instruments in and out of the joint too many times or uncarefully. If you have a tight varus knee with a little bit of arthritis, this can be difficult. So it's important to use those tips that we presented earlier on maximizing and optimizing visualization, particularly for that posterior horn of the medial meniscus. If you're still not able to do it despite trying all of those things, there are other things that you can do, such as puncturing or releasing the medial collateral ligament. Your instructors can teach you that, as that's a little bit beyond the scope of what we're trying to teach here. Again, make sure that when you're positioning the patient initially, you looked at their kneecap and made sure they weren't excessively internally rotated. And you want to look for that retained meniscal fragment again that we discussed previously. Prior to resecting the meniscus, you want to come up with your preoperative plan as to how you want to saucerize it, and that's really dictated based on the anatomy of the meniscal tear. And so this is just a good video of different ways of doing meniscus resection for different tear types. And this is an example of that refrained fragment. So the trainee goes in and sees that there's a meniscus tear. They do a debridement and they tell me that they're done. And then I go in and I probe and find this meniscal tear underneath the edge of the medial tibial plateau. And then we have to resect that. Obviously, you don't want to miss those because that's a common source of persistent pain post-meniscectomy. In general, these retained pieces often live either at the posterior root with the superior surface of the meniscus flipped behind the femoral condyle, or at the posterior horn body junction with this inferior fragment flipped along the medial tibia. So for optimizing your chances of success with a partial medial meniscectomy, you want to make sure that you optimize visualization, taking advantage of your telescoping and periscoping to ensure good scope position and rotation. And again, you want good knee position with slight external rotation to begin with, as well as slight flexion and valgus stress. Be willing to make accessory portals to avoid injuring cartilage. So, soft tissue heals, those portals will heal. damage to cartilage is not going to heal. And so if you need to make an extra portal, go ahead and do so. And remember, you can switch portals. A lot of residents will forget that that's something that can be done, and it's fairly easy. It may give you better access to an area of meniscus or a loose body. And again, don't force large tools into tight spaces. If the space is too tight, either use smaller tools or try to use other techniques to open up the space. When using shavers and biters, in general, you want to debride the frayed edges with a shaver, and then you can use a probe to define the extent of the meniscal tear or the meniscal lesion. Shavers typically work best from the tip of a tear, and they kind of extract or remove friable tissue, whereas the baskets or the biters work best from the base of a tear. So if you cut at the base, sometimes you're able to then grab the entire meniscal fragment and remove it, and then you shave what's left. Or you'll use the baskets to create friable, wispy tissue, which will then be able to be sucked and shaved. You want to try to minimize the number of times you're in and out of the joint. Obviously, the more you go in and out, the more you risk iatrogenic cartilage damage. When you're working in that compartment, it's very helpful to just obtain a good visual field and just stabilize your camera hand there, and then use your other hand to do all of the work. When you're working with your biter, you set the depth of your basket by biting in to the margin of the tear and then moving from left to right. So many folks will go in and they'll bite and then they'll pull back and look at what they just did. And then they'll go in and bite and pull back. And what happens when you do that is you'll lose the edge of the tear, or you lose your depth, and it makes it much more difficult to actually do your resection. So the analogy I like to use is doing a menisectomy is like eating corn on the cob. You want to munch, 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 munch to the side, and then when it gets all messy and it's on your face, you need to wipe. And so that's just like what you do with the meniscus. You get it on, you set your depth of your basket, and then you munch, munch, munch to the side. Then there's a big mess. You stick your shaver in, you clean it up a little bit, and then you go back in and you munch if you need to. You want to make sure when you're done that the edges are smooth so that there's a minimal risk of re-tear. So that's it for this video, and hopefully you all have learned quite a bit and will able to successfully complete your diagnostic arthroscopy, and it will make things easier for loose body excision and partial menisectomy. Good luck.